diabetes 15 years earlier. So it's early vascular aging. Despite the fact that you have 40 candles on your birthday cake, your vessels are 55 years old. And one of the most important things here to see is we are considering that basically obesity, the visceral fat, which is thought to be a very, very important player here, and now over the course of time, day by day, week by week, years by years, will lead to all these pathologies through different mechanisms. And all of a sudden we have type 2 diabetes and we say this guy is sick. Or we have also obstructive sleep apnea or coronary heart disease. And it is only now that we recognize or think that the disease is there. This all was developing over years and years, having the silence of too much fat, deregulated metabolism, and so on. Because we have to say that in obese you have not only more fat cells, but you also have dysfunctional fat cells, which at the very end cause inflammation and insulin resistance. And we're going to get back to that in a minute. But what we know is that all these pathologies, all these comorbidities have a clear association with body weight. So in particular, diabetes 5 times higher, sleep apnea, and so on. So there's a clear-cut association. So this is a very important other thought. While previously we thought all fat mass is fat mass and it's bad, we learned that in particular the visceral fat is the metabolically active and the deleterious fat. Subcutaneous fat might not be as nice, but it's not as dangerous in terms of cardiovascular events. And I always explain that to my patients. When you have a sumo wrestler, they have a lot of subcutaneous fat, and as long as they're physically active, they have no hypertension, no dyslipidemia, nothing. But when they stop doing their physical exercise, they very quickly get sick. And if you put them in the MR, you see that basically all the subcutaneous fat moved into the visceral fat. So this is one thing. But in the last years, we did discover the ectopic fat. And actually that was one thing I did my research on. I was the one who discovered the intramyocellular lipids and the association with insulin resistance. But we now, with new techniques, can assess that in the liver very early on. Pancreatic fat is very closely associated with the development of beta cell dysfunction. And when you are able to decrease the pancreatic fat, you will restore the insulin secretion in people with diabetes. But lately we have learned that we have perivascular, perirenal, and pericardial fat, which seems to play a very, very important role in the pathogenesis of cardiovascular disease. And if you have time, just download this paper, for instance. It clearly shows that there are clear-cut associations with skeletal muscle adiposity and dysfunctional endocrine system. So let's have a look on the physiology. It's so complex. If it was so easy, if it was just one factor, we could clear the problem easily. But we have the psychological factors. We have biological factors. We have the weight-bias stigma. We have mental health. We have depression coming in. And of course we have genetic factors and epigenetic factors, but we also have, of course, the lifestyle and the behavioral risk factors. And that's, I would say, also one important issue for us to work with the patient. However, we also have environmental and social factors which do play a very important role, and it is quite difficult to modify that as a physician. So that's the society which needs to take care of it. If we talk about obesity as a genetic disease, it's very rare because we have some very rare cases of monogenetic obesity. Most of the patients who come to me think it's either genes or it's hormones, and they want to have an explanation why they are obese. Well, we all know that we have a polygenic background of it. Very difficult for us to understand it, and each variant of all the genes we have has a very small effect. So let's deep dive into the environment. We have the macro environment, and again, if we look at that as a physician, we cannot do anything. The food environment, the built environment, the air pollution, that's all something which we cannot change, but it plays a very important role. This is something where we can help our patients to discuss in the microenvironment. We can also look into, is there any prescription which might prevent the patient from losing weight or increasing weight by side effects? Very frequently we only talk about eating. We say, hey, you eat too much. Well, that might be true, but we have the physical activity which frequently is very, very low. We say that the inactivity, the sitting, is the new smoking because people are not moving as we should. And we have all the other factors really contributing tremendously to this kind of a vicious cycle. And then, of course, we have the energy balance and the regulation, which is very complex, and we get into that in a minute. So why is it so difficult to maintain weight? We do see, let's just look to this slide here. If you had an intervention and you follow the people after that particular intervention, you do see that the people start to gain weight, and often they go back to the same weight when they started out. In particular, if you have done lots of crash diets because behavioral adjustment was not done. So when we look at studies, and that's an analysis done with a follow-up to up to 7 years, you see that the people have lost nicely their weight, but after 4 to 7 years, they basically are back to normal. And that is one of the explanations, but only one of it. The hormones do play a role, and we are talking about the set point of the body weight. It's very complicated. That's why we just try to make it easier here. We have the hunger hormone, in particular ghrelin, coming from the stomach, and we have a lot of satiety hormones. We have the hedonic eating balance and the homeostatic eating balance. The hedonic is something which is difficult to control over the course of time. We have to help our patients because some of the stuff is just so good to eat that it is tough for the people not to eat it. And if we forbid them to eat it, it's not a good diet. So when we look at the studies, you see that even during the study, there is an increase in those hormones driving hunger and reducing, increasing the desire to eat. And that makes it difficult for the patients. And we do see the important ghrelin, like a hunger hormone, to go up when you diet. Other hormones for satiety, they go down. So this is kind of a very bad situation. People want to lose weight, but physiology fights against, because the body wants to preserve the energy. So you need to know that for years and centuries and thousands of years, our body was always fighting famine. And that's why to preserve the body weight is one of the major issues. Now, as we live in the luxury of having food all over and we don't have to exercise and burn the calories, of course the risk goes up, in particular when you have certain genes. So If we now look what we could achieve, and that has been shown in many, many trials, if you have a small weight loss and maintain that weight loss, you already have the first improvement of metabolic parameters. And the more you lose, the better you can improve the comorbidities. And it's quite interesting down here, if the doctor is not addressing the overweight and the obesity problem as a major health threat, people don't take it for serious. So we do see that people who had been addressed, had been speaking about the obesity, had a much better success in the weight management. And I like that slide. It's, again, quite complicated, but look at that. The more weight you reduce, the better the benefits are. Starting out from 5% already, but 10, 15, 20% can help you a lot. For instance, we have been learned that in the direct trial, diabetes remission is possible if you reduce your body weight by 10 to 15%. And you might lose your hypertension completely if you're able to lose 20%. So it is very important that you lose, if possible, as much weight as possible. Needless to say, as an endocrinologist, I frequently have people with PCOS, and overweight plays an important role. Okay, just again here to reinforce that, the more you lose in weight, the better the drop in systolic blood pressure is and in diastolic blood pressure, the better the drop in HbA1c is. So, fantastic. However, as we all know from our daily work, losing so much weight and maintaining this weight loss is terribly difficult. So, lucky enough that in the last years we have been blessed by getting more and more medicine like the incretin analogs to help us to reinforce the weight management and to support our patients. And this is why the EASO, the European Association for the Study of Obesity, also recommends obesity medication as an adjunct, and you have to read this down here, to behavioral therapy, not as a replacement. What does that mean? We need to have a broader approach to coach our patients. And it does not need to be done by the physician. We need to have a lot of experts to help us. So if we talk about the meal plan, for instance, we cannot tell the patient, eat this and that diet, because we first would have to do a nutritional assessment. And then we have the nutritionist, the dietitian, the health educator to help them to get a healthier meal plan. The same holds true for physical activity. If I tell my patients do more sport, they say, "Ooh, God, as a kid, I never liked sport. Why should I do it now?" So we have to increase the physical activity, and sometimes you need exercise trainers and physical activity coaches or therapists to build up muscles first, you know. And then we have a lot of behavioral coaching, because frequently people have been so frustrated, have been so stigmatized, that they're always facing that they will not achieve what they should do. We have to support them. We have to set realistic goals, because frequently the people are well off what they could really achieve in terms of desired weight loss. And when we now look at the medications which we have, in some countries you have, besides of the incretins, you have some other drugs. Some of them are not available in Europe. We do have Orlistat, but these are the drugs which have really helped us a lot. And if we start to look at a couple of the studies, here the first one with liraglutide, you see compared to the placebo, those who were treated with liraglutide 3 milligrams had a nice weight loss, and it was about 6 kilograms, 6% more. And at that stage, we were so happy. When you do a study with people with diabetes and you give liraglutide 3 or 1.8 milligrams, you do see that the people also lose weight, but as we see in all the trials, people with diabetes tend to lose less weight. We don't understand the reason why, but this is seen in all the studies. If we now move on to semaglutide, you see that semaglutide 2.4 milligrams was very successful, and we achieved a double-digit weight loss. Hooray! That was first time. Everyone was very excited. And when we look in the type 2 diabetic subjects, again, we do see that 1 milligram is achieving a nice weight loss. People are already happy with this. But in the higher dose, you even get more weight loss. And people have been, of course, happier with this. If we now do the combination of intensive behavioral therapy and placebo or medication, you get a much better weight reduction, of course, even in the placebo group, because this is the lifestyle. And it's additive in terms of weight loss when you have a good behavioral therapy. And let's now move on to tirzepatide. It's a twin creatine. Why? Because we not only have GLP-1 receptor agonism, we have GIP, glucose-dependent, insulin-dependent peptide receptor agonism. And the GIP plays an important role, as we learned, in the regulation of the insulin secretion. It does more than 50% of the insulin secretion, glucose-dependently. That's why it's safe also for people without diabetes. It increases the fatty acid uptake in the white adipose tissue and regulates it in a favorable way. It has some central nervous actions which seem to be also associated with less side effects, better tolerability when you combine it with GLP-1, and you have an increase in adipose and splanchnic flow and an increased bone formation. So if we look at that, we see, yes, there are both GLP-1s and GIP influencing the brain to decrease food intake, altering the insulin sensitivity in adipose tissue, improving insulin secretion, and delaying gastric emptying. And that's a busy slide, but you see where you do find these receptors working, and if you put them all together, you end up, and this is what we want to look at, having a tremendous improvement in not only body weight, but also other body weight related risk factors. So let's have a look in the studies. The studies were basically called the SURMOUNT program, and tirzepatide can be given as a 5 milligram, 10 milligram, or 15 milligram dose, but you have to up-titrate it, and we have been involved in many of the tirzepatide trials, and you need to have 4 weeks of 2.5 milligrams, and then you can maintain that dose, and that was randomized for 5 mg. If you were to 10 mg, you had another step with 5 milligrams for 4 weeks, and then you went up to 7.5 for 4 weeks, and up to 10. So you always need to have 4 weeks in between to have a intermediate dose to go up to the final dose, like 15 milligrams. So what did we see? Look at that. The 5 milligrams achieved 15% weight loss. And there was a dose-dependent increase in the weight loss, with 10 having almost the same weight reduction as 15 milligrams. And look at that, we're talking about 20% weight loss. And this is gradually going down very nicely. It seems to level off with 5 milligrams, but here there is hope that we can, even after 72 weeks, have a further weight loss. And when we look at those people achieving 5% weight loss, which in previous years to us was already tremendous success, you see now that even in the lowest dose, 85% did achieve this. But when we look into those achieving, and we could never ever have 20% weight loss with anything like Orlistat and so on. Now we're talking about more than 50% with 10 milligrams achieving 20%, and even a third achieving 25% weight loss. I think this is fantastic in terms of support to the people to lose their weight. And this is all achieved with no bad surprises in terms of the adverse events, because they were basically known by the GLP-1 receptor agonists. You always, I mean, decrease in appetite, it's basically what we wanted with this drug. It's not an adverse event. But you see no major surprises when you use twincretin. Of course, yes, some of the people could not tolerate it, in particular at the higher dose. But my experience is when you guide the people with a good nutritional coaching, and potentially when you up-titrate sometimes, you need a little PPI, and then it's well tolerated because of the side effects of delaying gastric emptying. In people who have GERD already, the gastroesophageal reflux might be a little bit worse. So what happens when we stop the treatment? And this is done in the step 1 extension. Some people who were treated with semaglutide, I mean all the people treated with semaglutide, were stopped, and then they were followed, and unfortunately you see the weight goes up. And the weight goes up if you look at the different weight loss categories. Of course, the more you have lost, the more you have a weight regain. However, they're still doing much better compared to before. But this also tells us treatment is necessary. If you treat someone with blood pressure and you would stop the drug here, blood pressure would go up. Everyone would talk about adherence. Here people say, oh, it doesn't work, which is ridiculous. And I keep telling the people in Germany, hey, this is not an antibiotic. We cannot just heal the infection. Obesity is not an infection, it's a chronic disease. And the same, if we look here, you can see with tirzepatide. This was a study where people in an open label received tirzepatide, and then they were randomized to placebo or to tirzepatide 10 or 15 milligrams. And you see, wow, there was a tremendous weight loss in the 36 weeks of open label treatment. And then those who were put on placebo, unfortunately, regained weight, whereas those who were put on or kept on tirzepatide at the end achieved a weight loss of 26%. Again, this underscores the need for further support. Actually, I can tell you that many of my patients, even after the first 2 injections, already say, hey, what is this? My craving is totally gone. And that cannot be done just by telling people something. We are just giving a hormone, and that changes the brain, that changes the hunger and the appetite. So I'm a strong believer that this interacts with the regulation of satiety and hunger. So the NICE guidelines in Great Britain are regulatory guidelines, and they are always important for the NHS. And you see, they have just released a quite extensive guideline to include behavioral changes, diet, physical activity, psychological support, but also surgery and medicines. And when you look at the medicines, you see tirzepatide listed here, semaglutide, liraglutide, and Orlistat listed here. And actually, they are supposed to be reimbursed. And indeed, they are reimbursed, but they are not prescribed as often as the indication. Because when we look at data collected across several healthcare organizations with more than 2 million people, it's a shame. Look at that. People with a high degree of obesity, less than 3% do receive a prescription of an anti-obesity medication. So I think we should take it for serious because we have evidence that we can help our patients by prescribing these drugs together with behavioral changes. So what's going to happen in the future? Well, applications. And you could add in cardiometabolic, the renal, and the liver. So in the States, Bob Eckel and his group are setting up a new subspecialty where people have a cardiovascular training and a metabolic training in order to take care of that, to be specialized in that. And we are trying to do this in Europe, but it's quite difficult with all the different healthcare organizations there. So one of our aims is that we do have the cardiometabolic patient. We have to detect him, of course. Mm-hmm. He's being taken care by the GP, the family doctor. It's very important. But on the other hand, he needs a metabologist. We don't have to wait for sugar to appear to finally have a diabetologist to come into play. We need to have obesity specialists, we need to have lipid specialists, and so on. And I call it metabologists. We do have the cardiologist, we have the nephrologist, and the liver specialist, because all of them are looking at the same patients from different perspectives. So what we need to do, and this is our idea, that we will have the cardiometabolic specialists helping all faculties to sort out the best available treatment. And that also includes lifestyle changes. If I was to see this patient, of course, I would have to check his nutritional report. I would have to check his stress coping. I would have to check his physical activity. But also, I would have to check the medications he has in order to be sure that none of the medications increases weight or whether suboptimally dosed blood pressure medication and so on. So this is what we are doing at the moment. Last night I had a web session with my friends. We are setting up a global initiative and we want to invite everyone, cardiologists, nephrologists, hepatologists, and also of course the GPs and endocrinologists in this umbrella to really help these people with the cardiorenal metabolic problems to best prevent that to appear. But if it's there, we can do a lot, and we need to help these people. So at the very end, let's put this together. Obesity is a chronic disease that can lead to early death. It's associated with a reduction in life expectancy. We have a lot of complications. We did talk about diabetes, the fatty liver, and of course the cardiovascular disease. We should add, because it's often not seen, heart failure, for instance. PEF is a major association with overweight. Unfortunately, we have to acknowledge that the body is fighting against weight loss. This is this set point of the body weight, where we need to learn how we might be able to overcome it and keep people from regaining weight. I think, and that's why I just repeat that again, obesity is not an infection which we can cure with an antibiotic. It's a lifelong fight that people have. But we as physicians should be there to help them, not to criticize them, because they are suffering so much. And we are also obliged to offer them help in all aspects of the treatment scale we have. This is lifestyle, but this is also medication. And we have learned that the incretin-based therapies, and now lately with the twin cretins, that we have large benefits on body weight reduction and an improvement of all these cardiometabolic risk factors. And we cannot and we should not withhold this treatment to our patients. With this, I thank you for your attention.
I thank you so much, Professor Jakob, for this rich and inspiring and practical presentation. It resonates in my heart a lot. A lot of the things you said is actually in my clinic. We're trying to do that. So we now welcome questions. Actually, we already have one question posted on the screen. So I guess we just go into that Q&A question because we're kind of running out of time. The Q1 would be, how do you explain obesity-induced microvascular dysfunction? Well,
we cannot really explain everything, but inflammation plays an important role.
Okay.
Free radicals appearing, that is all causing endothelial dysfunction. We have done studies in young insulin-resistant subjects, and we did find that in those with the higher degree of insulin resistance, the more you will find endothelial dysfunction.
Okay.
So I'm very much sure that this is inflammation, fatty acids, and so on.
Great. Well, there's a Q2, but I have a follow-up question for the Q1 that you just answered. So are we having methods, or right now there's a protocol or any kind of guideline for us to kind of early detection of that factors that such as inflammation, things like that, to early detect the risk factors for these pre-obesity patients?
Well, I think in the future, hopefully, we will get some lab markers. You might have the high-sensitive CRP, but as a clinician, I would mainly go for the BMI, the fat mass, the waist circumference, the family history, and also checking out all the conventional risk factors. Like many patients do have dyslipidemia. And it's low HDL, it's high triglycerides, and that is one of the markers to tell you, hey, there's something happening.
Exactly.
Yeah, I was in charge of the outpatient lipid clinics at the university in Tübingen, and we had the chance to do OGTTs and measure insulin. And we did find quite a few people who had full-blown diabetes and were undiscovered. And we did find in most of the others who had NGT, normal glucose tolerance, we did find a tremendous elevation of insulin. Indicative of insulin resistance.
Okay.
And if you have high insulin levels, you will have more build-up of triglycerides, and you have a lesser degradation of the triglycerides. And that's why this is a clear indicator of the underlying problem of insulin resistance.
Fully agree. We will talk about that later after the meeting. Let's go to the next question. Do we necessarily, or is it necessary to do thyroid sonography for patients before giving tirzepatide?
Basically, that goes back to that problem that with all GLP-1s, there was the rumor that you might have thyroid cancer. And I can say, besides of all the good results in terms of cardiovascular outcome and the improvement of cardiometabolic risk factors, we did get a lot of data for safety. Actually, last night, I was just going through all the adverse events reported in all the clinical trials, because we participate in a lot of these trials. And if anything would pop up, we would have seen that, because we have so many people now in randomized, often placebo-controlled trials, where if there was anything happening, we would catch it. There's nothing yet. We are still assessing in all the studies calcitonin and everything. And if you have a patient who comes into and wants to participate in a study and calcitonin is high, we first would have to work it up.
Okay.
So I would do a thyroid sonography and measurement of TSH and everything as an endocrinologist anyways in people with obesity, because we had done a study And we lost, I think, 15% of the people who wanted to participate because they had hypothyroidism. And I think we should not forget the basics. I mean, that is not the cause for it per se, but it's contributing to it.
Okay, okay. So okay, this is the question number 3. Can the dose or injection frequency of tirzepatide taper down when the body weight goal attained? Well, that's the question. Yeah, can you stop the medication?
Actually, we are currently at the beginning of looking in studies what would be the best technique to do this. We have done that in some of the trials because the day before yesterday I had a patient in the SURPASS cardiovascular outcome trial who is down to a BMI of 21 now. So he said, don't want to lose further weight.
Right.
So we have down titrated him to the lowest dose allowed in the study, which was 5 milligrams. But still with this dose, he had a hard time to increase his body weight.
Oh, so he's still losing weight.
So he had maintained it on the very low level, you know. He was a BMI of 21.
So he was trying to maintain weight or keep
well,
losing
actually,
weight.
he was in this cardiovascular outcome trial over 4 years.
Oh.
And he has been certainly assigned to tirzepatide. So at the very moment, in terms of the label, we don't have any clear data how to down titrate it. But if you, of course, if you're in the highest dose, you can go down to 5 milligrams, you know. But we still need to do clear research to understand. There might be a phase where you push forward the weight loss, let's say over a year, and then there should be a time where we are not fighting against or for further weight loss. We are fighting for weight maintenance. And we might withdraw the component even, or decrease the dose at the lowest tolerable dose. Yeah.
Yes. Okay. I guess the question is still under research. Question number 4. Thanks, Dr. Stefan, for your fabulous research. According to SURMOUNT-1 study of body composition, GIP also has a buffer effect of white adipose tissue. Well, can we say that GLP-1 GIP drug has a better reduction of body fat than GLP-1 only drug?
Well, quite difficult to say because we would have to have a head-to-head comparison. But if you look at the data, you do see that people treated with tirzepatide do lose more weight.
Right.
So then they also lose more fat mass.
Right.
And that has been shown in many studies. I think when it comes to fat mass loss, we basically can follow the change in body mass. But this is currently a major discussion about sarcopenic obesity and so on. And I think in the future we will have to discuss that more thoroughly, because people with obesity, for instance, men with a low testosterone, and the whole story around it, inactivity and so on, frequently have, to start with, a low skeletal muscle mass. And you know this as well, if you would want to put your people on a physical activity program, in some people you first have to do MTT, medical training therapy, in order to improve muscle mass.
Okay, there's a question 5, but I do have a follow-up question with that, question 4. I recall there was a paper published in Cell Metabolism studying the mechanism GLP-1 GIP. They found that GIP has a receptor on adipose tissue, and on fast state, GIP would kind of suck up triglyceride and glucose, but at fast state, GIP actually stimulates adipose to release it. So I would guess that GLP-1 GIP dual peptide would have better effect on fat loss.
It might be. Let's take it that way. I know this paper. Yes, if we take all the data together, and in type 2 diabetes, for instance, they have a head-to-head comparison in the SURPASS-2, where they compared to semaglutide, 1 milligram, and there was a major weight loss, of course, when you had the higher doses. So when you have a higher weight loss, again, it's mainly driven by the fat loss. And whether it's GIP per se, I can't say.
Okay.
We are currently doing studies with a triple agonist.
Right?
Already.
Okay.
Yes.
Already.
It's
Was
going to
the glucagon?
Yeah.
Okay. The
retatrutide.
retatrutide. Okay, that's one thing. We're kind of waiting for that. All right. Question number 5. I guess that might be the last question. Maybe, if patients' BMI is below 24, with this normal BMI in Taiwan, after treatment, will you keep using anti-obesity medications? Is there any other approach you would prefer for this patient? Thank you.
That's a $5,000 question.
Oh, yeah.
I mean, definitely the patient needs to be treated. The question is, which kind of treatment is the best? And honestly, at the moment, we don't have the data yet. This is kind of experts' opinion. In some people, I would say, hey, great, let's go on lifestyle alone, but we have a close follow-up. And if within the next 2 months, 3 months, you start gaining weight, come back. I have patients in whom half a year weight maintenance was possible because they, over the course of time, had acquainted to a better lifestyle. But then there was a lot of stress, not enough time for exercise, the weight started to go back up, and this is when we reintroduced the treatment. Okay.
That's a fair answer. Okay, now question number 6. Can Professor share more about side effects that patients encounter when they start using tirzepatide, if possible, in the aspect of BMI above 28 or above 35?
So my background is that we participated in the SURPASS cardiovascular outcome trial, which is already now closing, but 4 years of treatment. And we also have the SURMOUNT cardiovascular outcome trial with obese subjects without diabetes about cardiovascular risk. In the first 4 weeks, when you start that low dose up titration, 2.5 milligrams, there are people who already at that time start to lose up to 4 or 5 kilograms because they seem to be super responder. There are people who seem to have more side effects, in particular people who had already gastroesophageal reflux. What we now do say to these people is, take a PPI around the up titration period. Maybe antiemetics also, just in order to your body, give your body a chance to adjust. We have not lost any patient in all these trials because of side effects. So there's another thing in terms of lifestyle. If you tell your patients that with this drug, your gastric emptying is being delayed, I always tell these patients, eat smaller portions. And don't eat the difficult to digest stuff. So have a lighter meal for the first 4 weeks for better tolerability. And that's a quite tricky thing because people eat less for better tolerability, not for diet. They do tolerate it better and they start losing weight. And then they emotionally are very, very happy and they say, wow, this is a great drug. So I think decreasing the portion size and probably also the meal frequency would be helpful, just to keep off this feeling of fullness and sometimes vomiting.
Okay. Seems like there are many questions. Question 7.
Yes.
Does Professor use BIA for body fat mass or percentage in your clinical practice with obesity management?
I do have
BIA.
body impedance analysis, which I think is very helpful because, number one, if you have these super diets, usually the first 5 days or 2 weeks, you lose a lot of water and you can pick it up.
Right.
Number two, we want the people to do physical activity and increase the muscle mass. We just want them to lose the fat mass. So it's very reassuring for us and for the patient. Yes, you have lost weight and you have lost fat and no muscles. The other thing is some people are unhappy with the weight lost, but they have gained muscles. So you can explain that to them.
Okay, we have only 2 minutes left. This will be the last question. Is it common for patients to encounter a weight loss plateau during their weight reduction process with tirzepatide treatment?
Right. This is what we see in most of the studies. Sometimes it occurs already after 4 to 5 months. In some people, it goes gradually further down. They achieve a plateau after a year. It seems to be better with a triple agonist. It seems to go down even after 70 weeks. But this is exactly when the body starts to counteract the weight loss.
Exactly. All right, I guess we're running out of time. I need 2 minutes to close. So on behalf of Eli Lilly and all the participants, I would like to sincerely thank Professor Jakob for his visionary leadership and commitment to transforming obesity and diabetes care. Your message, that the future of diabetes and obesity care must be patient-centered, lifestyle-anchored, and pharmacologically supported, I think is timely and vital. As we have seen, the duo GIP-GLP receptor agonists like tirzepatide are not just effective agents for glycemic control and weight